found it, 'cause I didn't know where we were.
I know, I didn't know where we were supposed to be.
Yeah. Hi.
My name's Nina.
Hi, Nina. Great. We were referred to. We'll keep things rolling. Boris Johnson, we see you. All
My
right.
name is Anna Claire Henry.
Great. Well, those are all very easy names. We know that.
Yeah.
You want to just start?
Sure, you want to just alternate?
Yeah. Why don't you lead off?
Sure. Hi, everyone. We're going to get started with the free paper session on Pancreas 2. So our first presenter is Hal Liu from the United States. So we'll get started.
All right. This one, let's see. Hello, everybody. My name is Hal Liu. I'm presenting today on the topic of angiotensin inhibition in pancreatic cancer. I have nothing to disclose. The renin-angiotensin system, RAS, is a well-known master regulator of cardiovascular homeostasis. Multiple angiotensin system inhibitors, called ASIs, have been approved for treating hypertension. In addition to regulating blood pressures, RAS is a key pathway to inflammation, fibrosis, and wound healing. In solid tumors, local angiotensin system enhances tumor cell proliferation and growth by acting as a paracrine or autocrine signal in the tumor microenvironment. It modulates the recruitment and function of stromal cells, such as fibroblasts, endothelial cells, macrophages, and neutrophils, leading to increased secretion of tumor growth factors and contributing to an immunosuppressive microenvironment. Before ours, a series of Japanese studies observed encouraging survival benefits if locally advanced or metastatic patients were ASI users. Their phase 1 trial showed superior survival compared to historical control, but their phase 2 trial failed to reach the primary endpoint. However, the proportion of metastatic and locally advanced patients in different studies were different. Therefore, we first set out to answer the question, what are the effects of chronic ASI use on PDAC patients with different stages? In this previously published retrospective study in a cohort of patients in MGH, I characterized the effect of ASI use in 3 different groups. The first two groups were not resected due to metastatic or locally advanced disease, and the third group of patients were resected. We defined ASI use as taking ASI at the time of diagnosis and continue to take ASI for at least 28 days throughout the follow-up period. We discovered that the use of ASI had no impact or minimal impact on survival if the primary tumor was not resected, shown on the left and in the middle. However, if the primary tumor is resected, chronic ASI use is associated with significantly longer survival, shown on the right. To further understand the effect of chronic ASI use on resected PDAC patients, we performed a follow-up retrospective study at UPMC. This is our second single institution retrospective study. We included patients who had resected PDAC from 2010 to 2019, and we collected all relevant and available clinical pathological parameters and used the same definition of chronic medication use when adjusting for medication used for treating comorbidities, including ASI. We have a total of 742 patients were included in this study. 349 patients were categorized as ASI users, and 393 patients were not ASI users. Their cancer-associated parameters are comparable. However, patients with ASI use were older. They also had higher incidences of coronary artery disease, hypertension, hyperlipidemia, and diabetes, and have a higher usage of beta blockers, diuretics, metformin, and statins. Therefore, we controlled for all these factors in our multivariable regression model. So first, in Kaplan-Meier analysis, the median overall survival for non-ASI users is 27.6 months versus ASI users of 37.0 months. This is shown on the top. In the multivariable adjusted analysis shown in the bottom, ASI is independently associated with longer overall survival with a hazard ratio of 0.71, represented as the dot and confidence interval of the hazard ratio on the left side of the vertical dotted line. This result is after adjusting for all the covariates shown in the last slide. We proceeded with propensity score matching analysis as another method to control for comorbidities and their treatments. We have 422 patients, 211 in chronic ASI use and 211 without, were selected into a matched cohort. After matching, there were no significant differences in age, incidence, or treatment for comorbidities shown on the bottom right. Chronic ASI use is associated with longer survival in univariate analysis in the propensity matched cohort, here shown on the top. Again, chronic ASI use remained independently associated with longer overall survival with a hazard ratio of 0.74 after adjusting for the clinical pathological parameters shown on the bottom. We performed sensitivity analysis by evaluating the effects of stattin and metformin using the same definition and statistical methods. In each propensity score matched analysis, both metformin and stattin were not associated with longer survival, but in the same model, ASI use maintained its significance in association with longer survival. To maximize the statistical power and estimate ASI's treatment effects, we then analyzed our entire cohort using inverse probability weighting analysis to calculate the average treatment effects of the treated and the average treatment effect, respectively. In the pseudopopulation created by inverse probability weighting, ASI is again independently associated with protective ATE and ATT on overall survival. Lastly, just to highlight that chronic ASI use is likely benefiting resected PDAC patients through a different mechanism to cytotoxic chemotherapy, we did a subgroup analysis using the patients who responded optimally to chemotherapy. We have 82 patients who responded favorably to neoadjuvant chemotherapy and had no more response to adjuvant therapy. However, among those 82 patients, if they are chronic ASI users, they still have longer survival than non-users. This suggests that ASI act through a separate mechanism than the chemotherapy regimens given to the patients. I don't know how that happened. Well, that's basically the end of the data slides. So in summary, ASI use is associated with longer overall survival in resected PDAC patients by univariate and multivariate analysis and propensity score matched and inverse probability weighted analysis. And there are some significant limitations to this study. Again, this is retrospective. The biggest limitation that we have is that we do not know how long the patients were on ASI before they come presented to us. So the only way that we can answer a question of whether adding on ASI after diagnosis would also still give us the survival benefit that we observed, that is unknown and needs to be answered by a prospective trial. And thank you very much.
So this paper is open for questions.
Have you looked within the tissue to see if there's any evidence of any type of difference between patients on ASI, since it does have potential effects on the tumor microenvironment?
Yes, we have in the cohort in MGH. So we did. So we believe that the use of ASI is actually inhibiting the renin-angiotensin system on the cancer-associated fibroblasts and potentially also on cancer-associated macrophages. So it reduced the stroma production from the fibroblast. And what we have consistently observed is that it reduced the hyaluronin level in the tumor. So we originally thought that it would decrease significantly the collagen level. It was shown pretty consistently on mouse models, but we did not necessarily see that on the human samples. But like the collagen turnover is a very complex process. Even if it did not reduce the content, maybe it reduced it changed the proposition. And we did in human samples observed a switching of the phenotype of the cancer-associated fibroblasts from a more FAP positive phenotype into a more alpha SMA positive phenotype. I think that the later phenotype is associated with a little bit better clinical outcome that has been shown consistently by retrospective studies. So I think there's still a lot of things to be answered, but it's that's I can answer. That's what I can answer.
Just one last question. Any hypothesis as to why there's such a difference between those that are resected and not, and why it doesn't seem to have an effect on those that are metastatic or locally advanced?
Thank you for that question. When we first started to look at all patients, we were expecting that patients without primary tumor resection would also show some benefit, but I think just as chemotherapy is difficult to treat, just as tumors that are larger are difficult to be treated by chemotherapy, probably the ability of using angiotensin to modulate the tumor microenvironment in a very large tumor, say 3 or 4 centimeter tumor, is probably also very difficult as well. However, I think the fact that it prolonged the survival in patients had resected tumor made me think that it actually affected the micrometastases. So we know that the micrometastases are already there when patients are diagnosed. It got the progression got delayed. I think it's just acting better on microscopic disease other than macroscopic disease. That's my hypothesis.
Thank you.
Thank you.
Thank you. Next, I'd like to introduce Dr. Boris Jansen, whose presentation is titled Inter-Observer Agreement and Assessment of Histopathologic Tumor Response to Neoadjuvant Therapy in Resected Pancreatic Cancer, the ISGPP1 study.
Thank you for the introduction. Let's just see how this works. Yeah. So thank you for the introduction. My name is Boris Jansen. I'm a researcher at the Amsterdam UMC Departments of Surgery and Pathology. And indeed, I'll be discussing the ISGPP1 study. So first, I have nothing to disclose. So as many of you know, neoadjuvant therapy is becoming more and more commonplace in patients with pancreatic cancer. First, as it appears to improve survival, and second, as it appears to improve resectability for a specific subgroup of patients. But it doesn't only provide these benefits, it also provides a novel histopathological parameter, which is the histopathological tumor response to neoadjuvant therapy. And the idea is that this novel histopathological parameter could be used to guide the choice for adjuvant therapy and to compare the efficacy of various neoadjuvant regimens in randomized settings. And of these systems that exist, the CAP and MD Anderson systems are most used, where CAP stands for College of American Pathologists and MD ACC stands for MD Anderson Cancer Center. And just to give you some feeling as to what this actually means, here you can see two examples of a good responder and a poor responder, where on the left you can see in the good responder a lot of fibrotic tissue, and on the other side you can see a lot of cancerous tissue, which is all the squiggly bits. And although these systems sound very useful, in reality they're actually quite difficult to apply. And these difficulties were thoroughly discussed and outlined during the Amsterdam International Consensus meeting on this topic. And the first issue that we mainly encounter is that we only have a post-treatment measurement. So we can't really compare how the tumor used to look prior to treatment and compare it to how it looks after treatment. Second, there are a lot of subjective definitions that define the categories within the tumor response scoring systems. And finally, there's a lot of intratumoral heterogeneity. So depending on where you sample within the tumor, you can find various types of response. And to basically try and further attack these issues and create a proper tumor response scoring system, we created the International Study Group of Pancreatic Pathologists during this international consensus meeting. And the first thing we basically wish to do is to try and find evidence of the earlier statements that we made. And this is what we did in the ISGPP1 study. So the ISGPP1 study has two primary research questions. And the first is, can expert pathologists actually reliably identify neoadjuvant treatment effect, which is necessary to actually use the tumor response scoring systems? And second, what is the actual inter-observer agreement of the CAP and MD Anderson scoring systems? For the first research question, we asked 18 pathologists from 8 countries to assess 30 treated cases and 30 treated naive cases. And here we found that in 76.2% of the treated cases, the pathologists actually accurately classified this case as treated. Moreover, in the untreated group, we found that in 49% of cases, pathologists correctly assessed the patient as untreated. So basically what we could say is that pathologists cannot reliably identify treatment effect in these patients. Then we looked at the inter-observer variation, where we asked 23 pathologists from 9 countries to assess the data from 50 patients. And we calculated an inter-class correlation coefficient, which ranges between 0.50 from poor to excellent, basically. So here we will first show the data of the GAP system, where you can find an inter-class correlation coefficient of 0.66. And here you can see a lot of data, but if you look at the top case, so basically every bar represents the data from one patient. And in the top bar, you can see that almost 75% of all pathologists graded the patient as GAP2, whereas almost 25% of all pathologists graded the case as GAP3. And as you can see, this is actually quite bad in terms of inter-observer agreement. And with the MD Anderson system, it's actually quite similar, although it does look a bit better. You have to keep in mind that it actually has one category less, which makes it easier in terms of inter-observer variation. So from this data, we can conclude that of the current systems that are most used, they're actually not really reproducible, and inter-observer variation is a big issue. So the basic conclusions of the ISGPP1 study are that pathologists can actually not reliably identify neoadjuvant treatment effect in these patients, and that the inter-observer agreement of current systems is really suboptimal. And these findings support the recently published ISGPP recommendations that we should ideally look at residual tumor burden instead of an assessment of response, also known as tumor regression, which will require a new GRS system. And just to give you a heads up, we're already taking the first steps with the ISGPP, which basically involve artificial intelligence to have a more objective assessment. And here you can see the ISGPP2 study, which is currently starting, where we used to use a segmentation model to identify tumor tissue. And then in the ISGPP3 study, we wish to use it to quantify tumor burden objectively, where we can, instead of getting a category, we can just simply get a number and correlate to clinical outcomes. So to summarize, the ISGPP1 study shows that the detection of treatment effect is unreliable, and that inter-observer variation of current systems is suboptimal, and that AI may provide an alternative solution. And I'll be happy to answer any questions.
Thank you. Any questions from the floor? I guess I have a quick question. Did any of the patients have radiation prior to that assessment? How did that influence their ability to predict treatment? And then how is residual tumor burden classified?
So for the first question, about half of the patients within the inter-observer variation assessment received radiotherapy in combination with gemcitabine, but we have not yet assessed whether this actually influences the ability of pathologists to apply these systems.
I'm Dr. Anand
And
from
for your
AIIMS,
second question,
New Delhi,
the
India.
actual determination
I'm
of
presenting
residual
our
tumor burden,
study comparing the two surgical
we
approaches
currently
during
think that
pancreatic
using these
adnectomy.
AI approaches, we could
For
basically,
this
quantify the amount of
talk,
pixels,
I have nothing.
literally, instead of, let's say, cells, to create a number which could be used to predict clinical outcome measure. So it's ideally you would have the amount of cells, but that's really difficult to do, and that's why we wish to use pixels.
Yeah, I mean, the challenge is you don't know how many cells you started out with.
That's the core issue about this entire system. So, yeah, that's the core issue, yeah.
Thank you.
Thank you.
Okay, and next we have Vincent Groot, also from the Netherlands, and he's going to be speaking on anatomic criteria to determine resectability in locally advanced pancreatic cancer.
Thank you for the introduction. So I'm going to talk to you about locally advanced pancreatic cancer and a new system that we developed at the Johns Hopkins Hospital to classify the LAPC patients. Actually, a good friend of mine, colleague George Jimenezis, was supposed to give this presentation, but he's unfortunately at home with COVID, so he asked me to present this in his stead. Nothing to disclose. So a little bit of background. We know that resection of localized PDAC offers the best chance of long-term survival. And then we also know that up to 30% of patients that present with pancreatic cancer have locally advanced disease when they present to clinic. In current guidelines, the treatment for locally advanced disease is still chemotherapy only, but we know from new studies that that paradigm is changing, and that a lot of these patients are now getting induction therapy with the idea of resecting them at a later time. We have multiple studies now from big tertiary referral centers in the US and Germany and Japan showing that we can actually resect quite a lot of LAPC patients with quite good outcomes. But what we also see is that there's a lot of differences in how we treat these patients, who gets resected, who gets induction therapy, and how long. So what we concluded was that there was a lack of a widely used system to identify these LAPC patients, and especially to see which one of those might be eligible for resection after they have gotten a period of induction chemotherapy. So what we tried to do is come up with a scoring system at Johns Hopkins to see if we can predict which patients have a higher chance of actually getting to resection, and to see if if the score that we came up with actually had a correlation with perioperative outcomes and disease-specific survival. So what we did is we included all patients between 2013 and 2018 who presented with locally advanced pancreatic cancer at Johns Hopkins. And we excluded all other patients, so the resectable, the borderline resectable, and the metastatic PDACs. And we excluded also the patients lost to follow-up. So the next slide is, I will go into the algorithm, but basically we made 3 tiers, LAPC 1, 2, and 3. 1 being patients with LAPC we thought likely to be able to undergo resection after chemotherapy, LAPC 2 unlikely, and 3 highly unlikely. And we followed these patients every 2 months for treatment response with the CT scans and CA19-9. So this is the algorithm that we came up with, and the time doesn't allow me to go through it entirely, but it basically you look at the 3 major arterial structures and the portal vein, and you go through each of them, and then you come in one of the 3 classifications in one of the 3 tiers. So the celiac artery, the superior mesenterical artery, the celiac or the common hepatic artery, and the portal vein or superior mesenterical vein. So we included 461 patients, 46 were lost to follow-up, so we ended up with 415 patients. And as you can see, almost 70% or 70% of them ended up in the LAPC 3 category, so the highly unlikely to go to resection. What we then see when we stratify these patients is that the LAPC 3 group had bigger tumor size, that the GI tract was more involved, but we also see that CA19-9 at diagnosis was not statistically different, especially between 2 and 3, and that the months of induction chemotherapy were also the same in these 3 groups, and that the different combinations of chemotherapies were all similar between these 3 groups. So we have these three groups, and then what we see is that in the LAPC 1 group, up to 63% actually underwent exploration, compared to only 17% in the LAPC 3 group. And if we look at resection, that almost half of the LAPC 1 group actually got resected, while only 11% in the LAPC 3 group. When we look at overall survival, in the non-resected patients, they were similar across the board. around 17 months, and in the resected patients, the median overall survivals were pretty promising, with not being reached for LAPC 1 and 2, and 31 months for LAPC 3. And if you look at the entire group, the median overall survival for resection versus chemo only was 35 months versus 16 months. So the limitations of this study, it was based on imaging findings, so CT scans with arterial and venous phases, which do not always correlate with the true vascular involvement. And we used experts, pancreatic surgeons at the multidisciplinary clinic to make the decisions to go for surgical exploration. And we haven't externally validated this algorithm yet. So to conclude, we think that prospective stratification of patients with LAPC at diagnosis in 3 different tiers based on the anatomic criteria provides a valid basis for prediction of which patients are more likely to undergo a future resection after induction therapy. So if you're interested in this study, it's been recently published in Annals of Surgical Oncology, so I encourage you to look it up and read it for yourself. I'm happy to take any questions.
Dr. Clancy?
Hi, Tom Clancy from Boston. Thank you very much for the great presentation. So a couple of things, you know, obviously resectability is always in the eye of the beholder, and in terms like locally advanced and borderline, sometimes I'm not really sure how to use these anymore other than for trial enrollment. And I wonder how much inter-observer reliability you had in your tumor ward. And obviously, sometimes the loudest voice in the tumor ward is going to be the one who makes the decision. And then, so number one, was that pretty reliable? And what criteria did you use? Number two, and then number three, you know, when you have this sort of LAPC 1 or 2, do you think that if a certain percentage got to surgery, that indicates that everyone with a LAPC 1 should get explored, or is that just the ones that made it as an indicator of who responded to chemo and its disease biology?
I mean, we started this project because we, you know, all the LAPC patients were like thrown onto a big pile, and we knew from
Good afternoon,
multidisciplinary
everyone.
clinics that there was a big
I'm
difference
Dr.
if you
Anand
only
from
have
AIMS,
some celiac
New
axis
Delhi, India. I'm
encasement,
presenting
or
our
the portal vein
study
is
comparing
involved.
the
There's a
2
big
surgical
difference in all
approaches
these,
during
different things.
pancreatic
So
adenoidectomy.
what we did is prospectively
For this
at the multidisciplinary clinic, we would say,
talk,
okay,
I have
based
nothing to
on who were
disclose.
there, I would say this is a 1, 2, 3. And then when we did the study, we actually, with Chris Wolfgang and Jin He, we went through all the scans, and then based on the algorithm that I showed, we would put them in those different categories. And then when we went to write up the paper, Elliot Fishman, who was the radiologist, he also helped us with the classification. Yes.
Thanks very much.
Just to clarify, were the borderline resectables, or what was traditionally we called borderline resectable, are they in this group, or
No,
they're excluded?
they're all excluded.
these
This
are
is
all the
purely locally advanced. Yeah.
Vince Picozzi, Virginia Mason, Seattle, Washington. I appreciate your presentation. It's always great hearing the work of the wonderful people at Hopkins. I'm curious to know how you currently incorporate other dimensions of success of surgery, such as the biological behavior of the cancer before and after treatment and the patient comorbidities, to name 2, in your formulation of this question.
Yeah, so this is a score based purely on anatomy. So we know that, you know, CA99 performance score is very important in these patients. So that's why the LAPC 1 pure on anatomy basis, you would think that we would resect a lot more, but it's still only 50%, and that's because, you know, people would progress, or the CA99 would stay very high, or their performance status would deteriorate. So yeah, those are definitely also important things that we haven't incorporated in the algorithm.
Okay, thank you very much.
Our next paper is Dr. Singh presenting comparison of posterior approach to standard approach in terms of circumferential resection margin, lymph node retrieval, long-term survival, a randomized controlled trial. Anybody willing to claim that as their project?
Oh, it might be a video. I think it's a
Is
video.
it a video? Oh, yeah.
Good afternoon, everyone.
Spectacular.
I'm Dr. Anand from AIMS, New Delhi, India. I'm presenting our study comparing the two surgical approaches during pancreaticoduodenectomy. For this talk, I have nothing to disclose. The perioperative outcome following the pancreaticoduodenectomy has significantly improved in the last few decades due to technical refinements, procedural standardization, and most likely because of advances in the perioperative patient care. However, the long-term survival remains dismal. The, the inclusion of the adjuvant and neoadjuvant chemo and radiotherapy have impacted marginally only. Various aggressive surgery have been attempted to improve the long-term outcome, including the venous resections, multi-vessel resection, and even the selective arterial resections have been done. Superior mesenteric artery first approach is another technique that have a potential to improve the long-term outcome. The premise for this is that the most common margin, positive margin after pancreaticoduodenectomy remains the superior mesenteric artery margin. So we hypothesize that by adopting the SMA first approach will help us in complete oncological clearance of the surgical margins. Further, this technique will aid in determining the SMA involvement before contemplating any irreversible step. Due to the early vascular control, it will reduce the intraoperative blood loss and might facilitate in the venous dissection if required later on. However, the evidence for this technique is very limited in the literature. So we did a pilot study from 2012 to 2015, included 39 patients, and we found that the posterior approach was significantly faster and yielded higher lymph nodes count, but did not impacted the margin positivity rates. So with this background, we planned this study to compare SMA first approach with the standard approach in terms of resection margins, lymph node retrieval, and long-term survival in patient undergoing pancreaticoduodenectomy for periampullary and pancreatic cancer. This was a randomized trial done after institutional ethics approval and CTRI registration from 2014 to 2018 at Department of GI Surgery AIMS. All consecutive patients undergoing pancreaticoduodenectomy for suspected or proven periampullary and pancreatic cancer having a good performance status and consented for a study were included. Patients are randomized into the posterior SMA first and a standard approach after exclusion of metastasis during surgery. Before the commencement of this randomized control trial, we did a pilot study and we standardized our surgical technique at the department. Similarly, we have standardized the assessment of margin during the surgery, which was our primary outcome in the study. The primary outcomes were the R0 resection rate and the number of lymph node retrieves, and secondary outcomes were the operating time, blood loss, post-operative complication rate, recurrence-free, and overall survival rates. By assuming the R1 resection rate, 36% in the standard approach and 22% in the SMA first approach, a sample size of 177 patients for each arm was calculated. How we plan to do a midterm analysis after accrual of 200 patients. For that, we are presenting the data. A total of 299 patients were assessed, 203 were randomized, 99 in SMA first, 104 in the standard group, 7 patients in SMA first, and 11 patients in the standard group showed no malignancy or non-adenocarcinoma malignancy in the final histopathology. So finally, 90 patients in SMA first and 93 patients in standard group were analyzed. Both groups were comparable in terms of age, sex, comorbid condition, need for preoperative biliary drainage, and preoperative albumin levels. A total of 10% patients had pancreatic head cancer in our cohort study. Now let's see the primary outcome. That is the R1 resection rate. The R1 resection rate were found to be 17.8% in the SMA first group and 21.5% in the standard group. There was no statistically significant difference between the two groups. Similarly, both groups are comparable in terms of the number of positive margins and the site of positive margins, We did a subgroup analysis in pancreatic and non-pancreatic cancer for primary outcome. Again, we did not find any significant difference between the two groups. A total of 18 lymph node retrieved in the SMA first group and 17 in the standard group. Again, both groups are comparable in terms of the number of lymph node retrieved in the as well as the lymph node ratio. Subgroup analysis showed the similar outcome. Now look at the secondary outcome. The blood loss was significantly higher in the SMA first group, that is 675 ml versus 600 ml. Other parameters like operating time, need for blood transfusion, and vascular dissections were similar between the two groups. Similarly, the post-operative complications were found to be similar between the two groups. Now look at the long-term outcome. After a median follow-up of 42 months, the recurrence-free survival were 62 months in the SMA first group and 57 months in the standard group. Similarly, the overall survival rate was 68 versus 64 months respectively. We did not find any significant difference between two groups. Now, just we'll look at the literature in context of the current study. There is only one RCT recently published by Sepp et al., which was a multicentric study. Besides that, there are a few comparative studies have been done, and this is a compilation of the all the 18 studies in which they found, this meta-analysis found that the SMA first technique was superior in terms of R0 resection rate. However, the both RCT did not find this difference. Similarly, a similar outcome we have found in the subgroup analysis in the pancreatic and non-pancreatic cancer as well. Total number of lymph node retrieval were again similar between the two groups. Now look at the other parameters. This meta-analysis of non-randomized studies had shown that the SMA first technique is superior in terms of the blood loss, having a lower pancreatic fistula and delayed gastric emptying, and shorter hospital stay. However, the incidence of diarrhea is higher in the SMA first group. But in contrast, both RCT did not find any significant difference between two groups, except the blood loss was found slightly higher in the SMA first group in our study. So, ladies and gentlemen, to conclude, posterior SMA first approach and standard approach for pancreatic duodenectomy for periampullary and pancreatic cancer were similar in terms of R0 resection rate, lymph node retrieval, recurrence-free, and overall survival rates. Thank you.
I don't think he's available. Oh, he is
There he is.
available for
Okay.
questions. Wow.
Good
This is
evening, sir.
modern technology. Terrific. Any questions? I guess I'll start off. My question is really, I view the SMA first approach as advantageous to prevent resection when you're going to achieve a positive margin. And it looked from that consort flow diagram that you excluded patients who went to the operating room and did not undergo resection. Is that true? And I would actually say that, to me, that would be a mistake, because in the anterior approach, you're more likely to resect somebody who has involvement along the SMA, whereas if you go to the SMA first, you might avoid resection in that situation.
So, if the tumor is already is unresectable because of the vessels involvement, and after actually we did randomization after the after laparotomy and assessing the resectability. So in consort diagram, we have excluded those patients who actually on pre-operative workup found to have unresectable disease, not during surgery.
I may have missed it in your presentation, but what level of difference were you powered to detect on margins? Like, I know it wasn't significant, but what level would you have been able to detect with your sample size?
So, before this randomized trial, we did a pilot study at our institute, And based on that, we found that the R1 resection rate is 36% in the standard approach and by assuming that in an SMA first approach, based on the various literature as well as our study, we assume it's around 22%. So 36% in the standard arm and 22% in the SMA first approach.
Okay, so about 10% difference?
Yeah,
Yeah.
right.
All right, thank you very much. Any other questions?
What time is it where you are?
Oh, I'm in India. It's midnight, around 2, early morning up to.
That's
2 a.m.
commitment. That's commitment. Thank you.
Thank you. Thank you, sir. Thank you everyone.
Okay, next we have Nina DeGraaf, who's going to be presenting on nationwide outcomes after robotic versus open pancreatic duodenectomy, a propensity scored matched analysis.
Thank you very much for the introduction. My name is Nina de Graaf and I am a PhD research fellow from the Netherlands, currently working in Amsterdam. And hereby I would like to present the nationwide outcomes after robotic versus open pancreatic duodenectomy. I have nothing to disclose. Robotic pancreatic duodenectomy aims to reduce surgical impact on the patient and thereby also to improve the post-operative recovery. Also, the robotic platform offers enhanced precision, which is especially beneficial for the pancreatic duodenectomy, and improved surgeon ergonomics. Furthermore, robotic pancreatic duodenectomy may improve outcomes as compared to the traditional open pancreatic duodenectomy. Over the past decade, there's been an increase in use of robotic pancreatic duodenectomy in specialized high-volume centers worldwide, but the evidence mostly relies on single-center, very high-volume observational studies, and no large multi-center studies or randomized controlled trials comparing the robotic approach with the open approach are available. So what about the implementation of robotic pancreatic duodenectomy in the Netherlands? In 2016 up to 2019, the LALABS 3 training program was performed in the Netherlands in centers with a minimum volume of 50 Whipples per year and 15 surgeons per trained. And the outcomes of this LALABS 3 training program were published in Annals of Surgery last year and showed the feasibility and the safety of the training program. The aim of our study is to compare the first 5 years of robotic pancreatic duodenectomy to open outcomes using propensity score matching to minimize the treatment allocation bias within the Dutch pancreatic cancer audit. So we included all consecutive cases from 2014 to 2020 on an intention to treat by method. So the converted cases were analyzed in the robotic group. We excluded patients with M1 disease, arterial resections, and chronic pancreatitis as indication. And here you can see the propensities, the variables that we use for the propensity score matching, which we retrieved through logistic regression and known confounders. The primary outcomes of interest were safety variables in hospital and 30-day major morbidity and mortality and failure to rescue. And furthermore, we were interested in the intraoperative outcomes, length of stay, readmission, the procedure-specific complications such as fistula and bleeding, and oncological short-term outcomes. Also, we did several sensitivity analyses to look at the influence of volume on the outcomes, where we analyzed where we excluded the cases from centers below the advised volume of 20 RPDs per year. Also, we did an analysis for the learning curve, excluding the first 30 robotic procedures per center, and we analyzed patients with and without major morbidity separately. So here you can see the patients that are included. So we included about 4,500 patients in the study. And for the matching, we ended up with 507 patients in each group. The robotic cases came from 9 centers, the open cases came from 19 centers, and the overall experience of the robotic procedure, the annual volume was 20, and the overall experience was 47. Here you can see the baselines before and after matching. Most importantly is that the important baseline characteristics were the differences were minimized after the matching. Also shown here is the difference in the fistula risk. So before matching, there was a higher fistula risk score in the robotic group as compared to the open group. Also here you can see the different fistula risk categories. And after matching, this difference was eliminated. Regarding the intraoperative outcomes, the robotic procedure had a higher, longer operative time, a lower blood loss, and a conversion rate of 8.9%. And the texture was equal between the two groups. Most importantly, the post-operative outcomes, there were no differences found in major mobility, mortality, and VO2 rescue between the two groups. The procedure-specific complications, there were no differences found in the post-operative fistula. For the RPD group, there was a higher rate of post-pancreatectomy hemorrhage, lower rates of chyle leak, and lower rates of surgical site infections, and the number of re-interventions performed were equal. There was no difference in length of stay, readmission, and time to adjuvant therapy between the groups. And regarding the oncological outcomes for the malignant cases, we found in the RPD group a higher rate of R0 resections and a lower rate of total resected lymph nodes. Here you can see the sensitivity analysis before and after matching, and what is most importantly that all sensitivity analysis did not influence the results. Lastly, the impact of major mobility on length of stay. On the left, you see the patients without major mobility, where the RPD group has a lower length of stay. And on the right, you can see the patient with major mobility, where there was no difference in length of stay. So to conclude, in the study, we found no differences in major mobility, mortality, and VO2 rescue. However, we did find differences regarding post-pancreatectomy, hemorrhage, chyle leak, wound infections, and R0 resections. However, randomized controlled trials should properly investigate these findings in centers who have completed the learning curve and are high volume. So to conclude, the Diploma 2 trial has just started running in last January. And compares minimally invasive and open pancreatonectomy in high volume centers in Europe. I am the coordinator of this trial, so if you want any more information, please contact me. Thank you for your presence and happy to take questions.
This paper is open for discussion.
Great presentation. Patricio Polanco from UT Southwestern in Dallas. I congratulate you and the team really for reporting what it appears to me that early experience, yet it's only 6 years, and it's probably more like 40 or 50 years doing open Whipples. But what we know, or we've learned, from the work of Pittsburgh and also in our own institution, is that there's an institutional learning curve and then there's an individual surgeon learning curve. Mm-hmm. From your data set, can you speak out of what is the actual learning curve that have achieved the surgeons that are performing robotic surgery? Do they have actually granularity to know how many Whipples have been done by individual number of surgeons? And my second question or comment is, you still seem to have a high rate of clinically relevant pancreatic fistulas in both groups, in fact, when compared. We did exactly the same analysis with the NSQIP data set here in the United States in a propensity match score fashion. And in both groups, the rates of fistula were lower. Yeah. Could this be related to drain management or something else regarding to the technique that could explain why the rates are higher?
So regarding your first question on the learning curves of the individual surgeons, unfortunately, in the registry we do not have this data. However, my colleague who has been coordinating the training program, the LALABS 3 training program, he's still working on the data. So we did a preliminary publication on the safety and the feasibility, but we will also report on the learning curves, and in this study we have the data. But unfortunately for this study I did not have. But I understand your question. Regarding the high rates of fistula, this is of course also what we noticed, and it's also high as compared to the literature. However, in the Dutch registry, we register very well. Also, during the years 2018-2019, there was a trial running, the PORS trial, which investigated an algorithm on early management to prevent later complications. This can cause the high rates of major morbidity, as the rate of major morbidity was mostly due to the high rate of Clavien-Dindo 3 complications and not the Clavien-Dindo 4 and 5. I hope this answers your question.
Any idea what is the drain management in your high volume institutions? Everybody gets a drain, because sometimes it's capturing the rate of fistula based on, reading the drain through wall.
Exactly. Yeah, so the drain, as you say, a prolonged drainage also causes a Clavien-Dindo 3 complication. We do not have any data on on the drain, the duration of the drainage within the registry. Every patient gets a drain after a Whipple, so part of the major morbidity group can be caused by prolonged drainage.
We're going to close this paper just in the interest of time.
I'm Sudhir from India. I just wanted to ask you, although you have said that statistically speaking, the re-exploration rate was not different between the two groups, but I noticed that it was still 47 cases that you re-explored in the robotic arm, as versus to somewhere around 20 in the open arm. Can you explain the difference?
So if I understand your question correct,
Re-exploration rate.
so the surgical reoperation rate was not significantly different between the two groups, but was higher.
The numbers were much higher in the robotic arm.
Yeah, that can be caused by the high rate of post-pancreatectomy bleeding. We do not know the reason for re-exploration, so this should be investigated in the randomized control trial. Yeah. Thank you.
Next paper, Dr. Henry, the impact of complications after resection of pancreatic cancer on disease recurrence.
Thank you for your introduction. My name is Anne-Claire Henry, and I would like to share with you the results of a study about the impact of complications after resection of pancreatic ductal adenocarcinoma on disease recurrence and survival. I have no disclosures. The oncological prognosis of patients with pancreatic cancer is poor, and pancreatic resection is technically challenging and associated with a high risk of complications. The occurrence of major complications has been identified as a potential risk factor for early recurrence, and this could either be explained by failure to start or complete adjuvant chemotherapy, or by tumor progression due to a systemic inflammatory response. However, it remains unclear to what extent these causal pathways contribute to early disease recurrence, and insights in these causal pathways may help to determine a focus for improving oncological outcomes. Therefore, the aim of this study was to investigate the impact of post-operative complications after resection of pancreatic ductal adenocarcinoma on disease recurrence and survival, and to evaluate the role of adjuvant chemotherapy as a mediator. A nationwide observational cohort study was performed and included were all patients undergoing resection for histologically proven pancreatic ductal adenocarcinoma, between January 2014 to December 2017 in all 18 centers collaborating in the Dutch Pancreatic Cancer Group. Excluded were death within 90 days after resection, metastatic disease, and neoadjuvant treatment. The outcomes of interest were the disease-free interval, also known as the disease-free survival, and the overall survival. First, we performed a multivariable Cox proportional hazard regression analysis to assess the impact of post-operative complications on the disease-free interval and overall survival. And adjuvant chemotherapy was considered a mediator, which implies that the impaired survival in patients with post-operative complications can be explained by their inability to start adjuvant treatment due to a delayed recovery. Therefore, a causal mediation analysis was performed, and in this analysis, a total effect is estimated, and it can be divided into a direct effect and an indirect effect via adjuvant chemotherapy as a mediator. On this slide, I will explain the causal mediation analysis. It is in fact based on 3 independent regression analyses, including the multivariable Cox from the previous slide. And based on these, effect estimates for each step of this causal pathway are calculated. And it results in a total effect, and the total effect can be divided into a direct effect and an indirect effect via adjuvant chemotherapy as a mediator. This baseline table describes a standard cohort of patients with pancreatic cancer. Most of them were male, aged 68 years. 38% suffered from a Charlson comorbidity index higher than 2. Most of the resection types concerned a pancreatoduodenectomy, and 74% of patients suffered from a TNM stage 2B or higher tumor. The outcomes, the post-operative outcomes were as followed. 29% of patients suffered from 1 or more major complications, which is defined as Clavien-Dindo grade 3 or higher. 63% of patients underwent adjuvant chemotherapy. Median overall survival was 20 months, and the median disease-free interval was 15 months. Individual complications were not significantly associated with the disease-free interval. However, this might be a power issue. More important, we have seen a significant association between major complications, including organ failure, with a shorter disease-free interval. On this slide, I present you the results of the causal mediation analysis for the association between major complications and the disease-free interval. And as said before, it is based on 3 independent regression analyses. And as you can see, the negative total effect indicates a significant negative impact of major complications on the disease-free interval. And this effect can be divided into a direct effect and indirect effect via adjuvant chemotherapy. The direct effect was not significant. However, the indirect effect via adjuvant chemotherapy was significant. And this implies that the impact of major complications on the disease-free interval is completely mediated by adjuvant chemotherapy. Also, for organ failure, a significant association was seen with a shorter disease-free interval, indicating the total effect here, the negative estimate. However, this total effect consisted of a significant direct as well as a significant indirect effect. This means that the effect of organ failure on the disease-free interval is only partly mediated by adjuvant chemotherapy, and the significant direct effect might have something to do with a major systemic inflammatory response that is associated with organ failure. In conclusion, major complications, including organ failure, appear to be significantly associated with shorter disease-free interval and overall survival. This effect is largely mediated by the use of adjuvant chemotherapy. And to improve oncological outcomes, one should focus on prevention of complications or on early recognition and treatment of complications before they turn into organ failure. In this way, recovery will be promoted and eligibility for adjuvant treatment might be increased. And another suitable alternative might be a neoadjuvant chemotherapy, of which the survival benefit for resectable pancreatic cancer is currently being investigated in several randomized trials. Thank you for your attention, and I'm happy to answer any questions.
Thank you. Any questions? I'll tell you that we, when I was at Sloan Kettering, looked at this exact question in a cohort from many years ago, back before we had really effective systemic therapies, when patients were mostly getting single-agent adjuvant therapies, if at all. And we did not find any difference in major complications with respect to disease-free interval or overall survival, which we had sort of thought is counterintuitive. I guess my question also, just a question of interest in terms of the design of the study, is how is disease recurrence defined? Was it a uniform diagnosis? Was it an appearance on imaging? Was it only after it had grown on imaging and been biopsied? Or how was that done, and was there a standard way of doing it?
Yeah, there was a standard way. We defined it as a histologically proven pancreatic ductal adenocarcinoma, so
Only biopsy.
only biopsy.
Any other questions? We've received word that our last presenter won't be able to join us today, so I guess that concludes this paper session.
Thank you. Very good.